Hi, everybody. Welcome back to the podcast on menopausal symptoms. I'm Pat Corrales. We're going to do a talk on genitourinary syndrome of menopause, a fairly common symptom equaling that of hot flashes and what to do about them. So, why do we have these symptoms? Well, what happens after menopause and the loss of estrogen is that we develop vulvovaginal atrophy. This occurs in 64 million women who are in menopause. 50% of them will have some symptom related to that. The major symptoms are vaginal dryness, irritation, plus minus a discharge, itching, actual painful intercourse called dyspareunia due to the decrease in lubrication with sexual activity, and urinary symptoms, frequency, dysuria, incontinence. When your gynecologist or family practitioner looks at your vagina, it's lost the normal tone. It looks dry. It has reduced elasticity. It's very fragile. And there may actually even be prolapse where the urethra actually is uh, sticking into the vagina. In some women, they actually have higher rates of urinary tract infection because as estrogen in the vaginal lining changes, the normal pH of that lining is actually increased, which promotes the bacteria that are not good for the vagina to occur, leading to a urinary tract infection. This vaginal pain occurs fairly frequently in a study of 4,000 European and another 1,000 US and Canadian women. There was painful sex, and that impacted beyond just the bedroom. A third of them no longer felt sexually attractive. That 58% of them that had the actual discomfort, which reduced their ability to have sex, and they lost their desire, and their partners noticed. 80% pain that impacted them basically reduced their willingness to have intimate relationships. And almost a third of those went ahead and stopped sex altogether. Urinary incontinence is another problem that women have during menopause, and the estrogen loss, which leads to thinning of their urethral lining, as well as pelvic muscle weakening and relaxation, can lead to bladder prolapse, again, due to the weakening of the vaginal wall. And although urinary incontinence is more common in midlife, it's not an inevitable part of aging, and it shouldn't be considered that. And you can complain about it to get some relief. Urinary incontinence that occurs more frequently than a week or requires using pads or is related to stress or urge. That's the cough, the sneeze. These are also related to disability, especially mobility, your ability to enjoy your life activities. And it can last quite a while unless it is addressed. The other thing that happens is urinary tract infections. Many women over the age of 65 have higher rates of urinary tract infections that recur, and almost 10% of them will have at least one per year. Urinary tract infections are up to a quarter as we age, and it is a big expenditure for Medicare. So this too is part of our menopause. And so when you take them all together, from the vaginal lining changes to the incontinence, to the sexual intercourse pain, to the repetitive urinary tract infections, we call that whole syndrome genitourinary syndrome of menopause. It's a significant disability. And so asking for treatments, thinking about this as not an inevitable part of aging, but a dysfunction of menopause is important to address with your providers. How do you address the vulvovaginal dryness and atrophy? Well, hygiene is important. You're going to remove soaps, dyes, perfumes, fabric softeners that can be irritative and exacerbate this dryness. You should have regular sexual activity, and that's why it's important to complain, if you will, about painful intercourse, because one of the things that's been found is that if the vaginal health requires an improvement in terms of blood flow, which depends on its use. So, this sort of use it or lose it causes the vagina to shorten, narrow, and become stiffer, which makes intercourse even more impossible. So, it's important to be attentive to that particular need and not embarrassed about asking for help. Vaginal lubricants provide temporary relief during and before sex, but they don't actually change vaginal tissue. Vaginal moisturizers do give a long-term relief because they actually do change the lining in a more positive way. Low dose vaginal estrogens reverse the atrophy and the dryness, and they are not absorbed to impact systemically, and they do not cause higher rates of breast cancer, uterine cancer, or endometrial cancer. They are very effective to treat locally, and they don't have a systemic effect, so therefore they can be used in women who have the risk for breast cancer, and w- checking with the oncologist even in women who have breast cancer. Systemic hormone therapies exist as well. These two reverse the vaginal changes, but usually we reserve them for symptoms other than the genitourinary symptoms, but that is changing. And it's important that if any spotting or bleeding occurs in a postmenopausal woman, that is checked out and not just ignored. Other considerations for the genitourinary condition is really looking for other causes and treating urinary tract infections. And there's no evidence that laser treatments or radio frequency treatments actually change the picture. They are touted, they're expensive, and it may not make a difference. So, as we said, lubricants, they ease the pain, they don't change the tissue, but they're useful and relatively inexpensive. Moisturizers you can buy over the counter as well. These do change the lining. They are expensive, but if you use them consistently, they're very effective. Vaginal estrogens, the local estrogens, can be used at a low dose. They are both E-string and estradiol tablets, as well as creams. And they do improve the vaginal epithelium, and they have absolutely no systemic effect. You should not use it if you have an active cancer, but that should be checked with your oncologist. Pelvic floor physical therapy has taken off recently, and these are the classic Kegel exercises. There are massages, there's biofeedback. They help with the actual muscles in the pelvic floor to reduce pain as well as to improve their function, and so therefore reducing incontinence. Muscle relaxants, cyclobenzaprine, benzodiazepines have also been used. for sexual pain as well as for pelvic floor dysfunction, and so have trigger point Botox injections into the pelvic floor. They have a 72% success rate. These are the Kegels. You can find apps on YouTube for doing them. They can be done at home. They can be done even at work. And they're very useful in the treatment of incontinence and painful intercourse. Hormone replacement. I think it's important for many women who have recurrent urinary tract infections to realize that vaginal estrogens will be helpful to reduce the incidence. And it's most effective in postmenopause rather than premenopause. And there are significant reductions in hospitalization rates, widespread infection, and even death. Systemic versus vaginal. So we said systemic is appropriate. It does help with sexual intercourse pain and incontinence and the night flashes and the night sweats. But it depends on your particular incidence of symptoms as well as your particular risks. And when you look at the local creams, the rings, the tablets, these are riskless. And so there's no reason why that shouldn't be a starting point. Systemic hormones do have some risks. And so what do we monitor? Well, it depends, okay? It depends really on the kind of estrogen that's delivered. And we have more and more low dose estrogen and different kinds of estrogen. The estradiol tablet versus the cream, there's really no difference in the use. The estradiol ring allows you to not have to think about it because it's exchanged every 90 days. It's not femring, it's e-string. Okay. Then there are newer estrogen therapies called selective estrogen receptor modulators. Estrogen is different in different tissue, and these selective estrogen receptor modulators work at different tissues. And so their advantage is that they avoid the endometrium and the breast. And so people will gravitate to that. The same with intravaginal DHEA. The interesting thing about that is that it is actually turned into estrogen and testosterone in the body. So some people feel strongly that testosterone is needed to help with the genitourinary symptoms that women have. But at this point, we don't have a lot of studies to support one over the other. And so most everybody starts out with local hormonal therapy and then moves on to systemic therapy depending on the response. If there is risks of breast and endometrial cancer, the local estrogen and hormone replacements are appropriate. They are safe. They do not have higher rates of absorption systemically, and they don't need to have surveillance or progesterone to protect the uterine lining for those women who have a uterus. Otherwise, the current recommendations for hormone replacements, systemic, are if you are under 60 years of age, if you have had menopause for less than 10 years, then your risk of having breast or uterine cancer is extremely low. And as far as how long to stay on these systemic hormones, that's going to be an individualized decision. And it's important that one of the things that we do in our practice is we always do risks for cardiovascular disease using the American Heart Association Prevent. And we also do a calculator for breast cancer risk. And we actually check for osteoporosis as well. And depending on the individual risk and the symptoms, we will go ahead and give hormone therapy. How long they stay on it has been recommended to be less than 5 years, but each person is different, and that's a conversation to have with your doctor. So, talk to your doctor, assess your risk. Don't be shy about talking to them about the symptoms you're having: sexual intercourse, low libido, incontinence, urinary tract infections. Ask for specialized care in the form of pelvic floor rehab and cognitive behavioral therapy experts, particularly for sexual dysfunction, and screen for your risk so that you know what to expect in terms of hormone replacement. So, with that, I encourage you to listen to our next podcasts and tell your friends about it. We'll continue to talk about menopause and how to get help. Thank you.